the last talk. I'm talking about the Bony Bankart, right? Thank you, all my fellows. So this is my way of the instability surgery. I do big share in for rotator cuff. For instability, I do the supine traction position. And I will have mostly 3 portals, but for Bony Bankart, I have an additional 5 o'clock portals for my suture management. Okay. So this is a position, right? I traction on the same side.
Arthroscopic access.
Yeah. So I think portal is important because when you're working on the glenoid, you need to have very good trajectory. So one portals on the just under the AC joint, another one is put in just above subscap. I put posterolateral portal like this. Yeah. So this is my portal for the Bankart. Bony Bankart, I will have additional 5 o'clock portals. Okay. So very important when you get in, you need to make a very good release. And always come from the back first to make my first stitch. And this second stitch is important. You need to go under the bone, not go through the bone. Okay. And I will close my first stitch first. Okay. And then I will slowly close it. So if you have very big bone, I will not tie the knot. I will pack the suture first and tie the knot later. Okay, like that. So this is very simple. It's not that fancy. I did not make double row, right? I just make a big bite. So don't worry about the over reduction because once you release the traction, the head will mold the glenoid to be flat. Okay. So I give you the second patient. This 27 years old, 20 dislocation, and he had the Bony Bankart, big piece. Yeah. Yeah. So this is my 5 o'clock, right? So you make it lower. The good thing is that you can access the lower part. So I use the needle. So this is the hip spinal needle, hip arthroscope, because it's very good. You have the needle. When you pass the needle, then you can pass the needle inside, and then you can use a dilator. You will not miss it because it's not easy for you to put the cannula in this 6 o'clock, 5 o'clock portal. Okay, so I think this is very important. And from the study, it's quite safe. This portal is far from the nerve. Okay, so this is my portal, right? And then I use a dilator, follow this. So you see that in the front, I have 3 portals, anterosuperior, anteroinferior, and also another one is the 5 portals. Then I use dilator. Okay. For this portal, sometimes I did not put the plastic cannula. I just put the half pipe on the slot cannula, right? So it's easier for you to pack the suture, okay, around the fragment. Yeah, I think this is the very important because when you're dealing with a very big piece, you cannot make a suture hook to make the big bite around the fragment, right? So now we put another anchors here. So I think this is the key step, right? After you get this portal, then I always start from the back. Okay, we release. This is a big fragment. You're coming from the back, and I think mobilization, like Amen said, is very important. Once you make a nice mobilization, your suture will very easy to pass to the fragment. Yeah, this is the chronic case. You see, big piece of bone. Right? So I need to make sure that I can make a very good mobilization until you see the subscapularis. Okay, like that. Okay. So after that, I always make my first stitch coming from the back. Okay. So next step is cleaning. I make a small trough. And then I make a stitch coming from the back. And the next stitch is I will go under the fragment, right? You see here? And then you can use like metal nitinol. This is easier because when you go through the fragment, sometimes the piece of bone stuck, right? If you use metal, it will be easier for you to pass yeah, this small piece of bone can go away. Okay, so this is another trick. I use a metal instead of the PDS suture. Okay, so after that you get this, and I pack the suture around. So someone use the like bone stitch go to the bone. I don't like that. Sometimes you can break that piece of bone. I prefer to go around the bone, not go through the bone. Okay. And then you see I pass the next one. I will not make a knot because if you make the knot, you close the space. You cannot, yeah, you see that after that you can pass this in. Okay, I think this is a key stitch, the 5 o'clock. Because the piece of bone always big around 4 to 5 o'clock. After that, the bone will get smaller. The upper one is easier, right? So after this, then you can pass the next one. Okay. And after I pass all the suture, then I start to tie the knot. Okay. So that will be easier. Okay. Start from the crochet first and then start the knot here. 5 o'clock. Yeah. So don't worry. Sometimes you feel like it's like over reduction. Don't worry about that because after you release the traction, it helps you mold the fragment to be flat. I never seen the fragment is over reduction. So, but we don't like under reduction. If it's under, you cannot collect it. You need over reduction like this. Don't worry. Okay. So it will be like this, right? After the repair. Okay. And then this patient also have the USAC. I do leg massage also. Yeah. After surgery, you see the healing is good. You see the fragment was healed nicely. Yeah. And the patient had good outcome after the surgery. Yeah. No limitation. And he go back to sports, right? So this the next scenario, this patient have the traumatic in dislocation, but the piece of bone is quite big. It's like this. It's like very big piece. Yeah, and also there's some small fragment here. So in this case with the patient that maybe I need to put the screw in if I cannot fix this fragment. So when we get in, we found that the patient had a big piece of bone. Okay. But I think this piece was reducible. So first I reduce the fragment first. It's torn to the upper labrum. So I pull, use a traction stitch, and I repair the upper one first. And then we repair the under, the 6 o'clock. Okay. And another stitch, I go to the fragment because it's big piece. Use a drill, and then we add the suture into the bone like that, and then reduce it. Yeah. So yeah, it was reduced nicely, and X-ray, CT scan found that it's a very nice reduction. Yeah, and patient had good outcome, good motion, and he go back to sports. Okay, full motion after surgery. Yeah. Okay. So if this the Bony Bankart is too small, so if you read the article from Hirosugaya, he said the piece of bone always get bigger, right, after the repair. But if the piece of bone is too small like this, I think it cannot get bigger. So it was 38%. It's too big. So this kind of Bony Bankart, you need bone reconstruction. So I prefer to use distal tibia. Okay, so we go into the rotator interval, okay, and put this piece of bone into the rotator interval, and then repair, fix the button, and also repair the label tissue back. Okay, so this is after the surgery. You see we have button in the front and in the back. Okay, so nice healing of the button, and then this is the after surgery. The patient have good motion. I also do leg massage for him and also the bone graft. Okay, he has good motion. Yeah. good stability, have some a little limitation, X rotation, but I think over time it will be better. This is about 3 months. Yeah. Okay, thank you. Thank you so much.